Put yourself in this scenario. You're coaching your patient or client through a squat. And as they approach the 90-degree mark, you start to see both knees cave in. This is typically what we refer to as knee valgus. Ask yourself, what is your next step? And based off that next step, why do you believe that knee valgus is happening in the first place? So that's a really familiar scenario, and typically the actions and the answers are as follows. Usually the action after that knee valgus occurs is to put a band around the knees and cue the patient to push out as they go through their squat. The answer that is usually followed to justify that action is usually blaming weak glutes. So in order to fire the glutes up, we put a band around the knees to start to strengthen and activate them so then they can help keep the knees in alignment during the squat. So I get it. The glutes are an easy structure to blame, and putting a band around the knees helps align the knees and makes us believe that life is good and that patient or client can then squat. The problem is it's not as easy as that. We need to start asking different questions, and ultimately we need to start looking at what is the source of this dysfunction. Sure, the weak glutes are part of the equation, but usually the position that the pelvis is in is what causes the weak glutes. So the glutes aren't really weak, they're just in a position that's causing them to be weak. And ultimately the position is what is the true problem. So we need to change the position so we can have the glutes in that mechanically advantageous position to then work exactly how we want them to. So to start to get after the true source, we need to briefly go over normal squat biomechanics. Now I have a whole video that discusses this, and I will link that in the description below. So if you haven't seen that, go back, check that out so you can be a little bit more familiar with the overall normal range of motion. But for this video, I want to key into that 60 to 90 degree range of motion. What I'm referencing is that 60 to 90 degree range of hip flexion. In normal biomechanics, we actually see more of an internally rotated bias position. So what we're referencing are the innominate bones in the pelvis. As we hit that 60 to 90 mark, we should have more of a bias of internal rotation, adduction, and extension at the innominate bones, also met with our coupled sacral nutation or a slight forward tip position. So we see this shift towards internal rotation because the line of pull changes. The muscles in the posterior pelvis, such as the piriformis, the glute med, the glute max, as we approach that 60 to 90 degree mark, the line of pull completely changes and it exposes them, and they're still contracting in the same way. But because the femur is in a totally different position, it actually contracts and turns them more into internal rotators. So now that we understand that, back to our knee valgus position. If a patient or a client cannot move into that desired internal rotation bias at the pelvis, and they remain stuck in an externally rotated position, how do you think they're going to try and find internal rotation? They're going to try to find internal rotation by staying externally rotated and compressed in the backside and drive the femur into internal rotation. This is the visual knee valgus that we see. It's not really knee valgus. It appears as knee valgus because the patient or the client doesn't have the ability to internally rotate. They remain open and externally rotated, and because of that, it creates this difference from the pelvis and the femur, which gives us our knee valgus. So now we know the source, and now we know why we see that knee valgus. What do we need to do to fix the source? Well, it's not the femur. So that's why placing a band around the knee isn't the best choice, right? The glutes are already in a shortened position at the pelvis. So when we put a band around the knee and just try to drive external rotation and abduction, well, the glutes are already in a shortened position at the pelvis. What we need to do is increase movement capacity. We need to work on exercises that are going to allow the pelvis into more of an internally rotated position. And we do that by really going after these posterior pelvis muscles and making sure that as they reach that 60 to 90 degree mark, they have enough length to go into internal rotation. If we have too much compression and stiffness back here, it makes it really hard as we go into that to continue to contract because everything's being restricted back here, and it's going to try to stay in an externally rotated position. So the first exercise we can do is a posterior hip stretch. We can do this on a foam roller, and it's a great way to start to open up this posterior capsule and drive internal rotation. So the pelvis or the hip that you are looking to stretch and open up, you're going to want to put that on the foam roller. So the setup is super easy. What we're going to do is put the knee on top of the foam roller. You're going to want to be towards the end of it. And then you go into a quadruped position. And you're going to try to bring the opposite knee up as high as you can. And then the first thing you're going to do is push over, and then you're going to go back. So you can combine this as one, but I find with patients it actually works favorably if you can kind of go over laterally to the left in this scenario, and then you start to sit back. And as you do that, you should start to feel that posterior capsule. I like to refer to it as the back pocket. And then once you're there, we're going to cue them to take 4 breaths as they go into that. And I always like to encourage them to kind of keep shifting and find different areas of tension and then breathe into it. If you find that a foam roller is causing your patient or client to pinch, go ahead and switch it out for something lower like an Airex pad. The foam roller is pretty high, so some people might pinch on the anterior side because of the compression coming up. The second exercise you can do is a piriformis stretch on the foam roller. The foam roller is great because it allows you to lean into it and really increase the intensity. And then it also allows you to start to rotate the pelvis to drive more of a stretch in that posterior capsule or posterior pelvis. So the setup is as follows. You would instruct your patient or client to put one leg, the leg that you are trying to stretch or that pelvis you're trying to stretch on the foam roller. You're going to bring it down. It's okay if that knee does not drop. Make sure that the patient or client doesn't feel like they have to force that knee onto the foam roller. And then all you're going to do is reach forward to increase that intensity. You're going to draw the opposite leg back and in, and you'll feel that hip really wind up. And then all you're going to do is start to draw the right pocket forward, the left pocket back, or vice versa if you're on the other side. And then same thing, we breathe into that. So the last exercise is a wall sit. And here's a couple things to consider. Use a ball to put in between the patient or client's knees. Now, this ball isn't to squeeze to turn on the inner thighs. It's to give a reference to maintain a neutral alignment to ensure that they don't want to go out because the ball would fall. Or you can also watch them to make sure they're not squeezing and causing that knee valgus. The second thing I like to do is to put a bench so that they can simply drop down. I find when people try to do wall sits, when they come up, it just doesn't look the best. It's a very poor looking squat. The person is fatigued. It's not the most favorable outcome. So have it so they can just fall to a seat. In this scenario, I need a box so that I can actually get the full range. And then as it relates to our problem of knee valgus, we're going to be in that 60 to 90 degree range of a wall sit. So all you'll do is put the ball in between the knees. We're going to put the whole body on the wall. Make sure that the back's flat on the wall. We're going to slide down by pushing the knees forward. And then all we're going to do is hold that 60 to 90 degree mark